Will Grinstead. I serve as palliative care chaplain here at Hall. Also the chair of the ethics committee for the East Central region. Been doing that since December. So great time to get into being the chair of ethics committee right before global plague. Just a brief kind of policy update and some case discussions today. I'm hoping that we can make it a lot more interactive than just Will telling you about a new policy, which is a pretty boring presentation, but really have an interaction about kind of real scenarios and what really makes conversations like this hard. I'm not positive it's going to take a whole hour, but it might. Last time you all surprised me. So let's go ahead and get started. So this policy replaces our old code status policy, and just real briefly, there is no change in the code status options that are offered. Thank you. That ends today's presentation. Sorry, just a little bit of levity there because this topic doesn't lend itself to a lot of levity. But yeah, just very brief kind of expansions, and honestly, just kind of putting in wording things that we kind of should have been doing, or maybe some of the time we're already doing anyway. So the policy gives some good guidance on some unusual scenarios or atypical scenarios maybe. About unbefriended patients or patients who have nobody to make decisions for them and they lack capacity. And then also clarifies some language about people with past advance directives, DNRs from like a SNF or post forms. Plus whatever else you want to bring up today, I guess, related to that. So let's start with a case. Fred's a 76-year-old male admitted from a SNF with signs of sepsis, heart failure, advanced dementia. Facility relays there's no family or friends involved in his care, and social work has been unable to locate any appropriate person to serve in this capacity. He has no advance directives, and he's listed as full code. Tell me if you've ever found somebody like this. Social work has also advised it'll be at least 48 to 72 hours before the court can get back with a signed guardianship petition, even if you fill that out right now. And the bedside nurse just called you to tell you that his blood pressure has been dropping. What do we do with people like this currently?
Everything.
Everything. Say more.
So you would wait for the court guardian to either treat them as if they already out there.
So when you say do everything, full aggressive care, go to the ICU if that's indicated, until we can get a guardianship. The guardian will likely say, well, doctor, what do you recommend? And you will say that I recommend comfort care. So like there's a span of time that we're going to do these things, knowing that later we're going to not do the things. Okay. So the updated guidance is to just consult ethics on these folks, and we can coordinate communication between physicians, risk management, and the CMO. To go ahead and change the code status to what the code status is recommended by the physicians. Again, this is a pretty rare scenario for a completely unbefriended patient. So like someone who in that hierarchy of decision makers about spouse, adult child, adult grandchild, and all the way down, 9 levels on the decision maker hierarchy that the state defines, that there's nobody. But they are out there though. Right, and then also this person is lacking capacity. They can't make decisions for themselves. So it's a pretty small subset of these folks, but I think pretty important guidance for those scenarios that you went into. What questions do you have about that? David?
So I don't know that I've actually consulted ethics before. What's the process like? I mean, do we just page you or diagnose you specifically, or is there like an order thing you'd like us to put in?
It's a really great question. Yeah. There's not actually a specific order. The best way to do it is just to contact the hospital operator.
Okay.
I do a lot of the ethics consults, but I'm not the only person trained for that. Kevin Bacchus, our director of chaplaincy, also has a wealth of experience in doing ethics consults and can do this just as well as I can. But yeah, great question. That's another slide, but I don't want as much information. Go ahead, Kristen.
So in these situations too, the family, we're reaching out to family members, because I often forget the order, the hierarchy.
Yeah, so this particular scenario that's up here right now, there's nobody. You've already kind of exhausted those options. That's a very reasonable first step. Yes. Anybody have Questions or thoughts about the hospital changing a patient's code status? Okay, good. This policy is meant to put that, to give you all the support that you need to do that, make those good decisions. So let's go second case. Ethel is a 76-year-old female admitted from a SNF with signs of sepsis, heart failure, and advanced dementia. Look, guys, I don't get very creative with cases sometimes. I just like to keep it simple. You know, let's just run the same scenario with a little variation here. The facility relays there's no family or friends involved in her care. Social work's been unable to locate any appropriate person. And Dr. Steiner hasn't even found anybody, so we know there's really nobody to serve that capacity. She has this DNR order from the SNF that she signed a few years ago. I think this is a will, I think. Currently, we're admitting those people as full code, and then this is a will, I hope, consulting palliative care about what's the best thing to do until we get a guardianship. Am I wrong in that? It's kind of a guess. What are we doing with these folks now?
I think it depends on who admits them. Like if they have a signed, post form or something, I would follow that.
Great, bonus points. We'll get a post form on the next case, but this is just one of those kind of short DNR forms from the SNF itself. If you ever have come across one of those, sometimes they are real fun and they just send them in a stack of papers like 3 days later. Not helpful. So did I guess right here that this is basically what we're doing on the whole?
I guess I would have just taken the DNR and not that.
Great.
Maybe that's not.
Yep.
correct.
You're leading the way. So that's exactly what this policy supports. It's going ahead and admitting DNR. It does not specify about the intubation status. Just encourage you to use your best judgment on these. We can't possibly describe every clinical scenario without intubation. So if you have a way you're leaning or you need ethics support for that, or just to consult palliative care for some support, please feel free to do that. That's kind of things we can answer pretty quickly. When there's a previous post form, this goes to Dr. Tim's question, use that post form to write admission orders. So again, I think everybody in here has seen a post form by now. Is that right? Okay, great. Bonus points for the whole class. You can use that post form to write admission orders. Yes?
So is that just saying that the post form trumps maybe a written DNR thing, or?
Yeah, so that's a little bit of a different situation where you have, like, you're saying, what if this person had a previous DNR order, let's say from December of 2015, and then in December of 2018, they did a post form. What should you do? Am I understanding the question right?
I was thinking kind of the opposite. I think the one I don't know, is more.
Oh, Sarah Ron. Sorry. I don't know why they scheduled her.
You usually say in advance directives to use the most recent one, although I think that would usually get you at least around the third base. If you have a question, please just ask about a certain scenario. I mean, honestly, at the end of the day, we're asking, what's the right thing to do for this patient? Right? There's a certain world we all live in where we need to check the right boxes so that, someone doesn't smack our hand or worse. But at the end of the day, we're asking, what's the right thing to do for this patient, given what's in front of me here, and who I have to help make these decisions, like family, friend, guardian, something like that. Does that help?
Yeah, I think I'm going into more of the weeds of things, but yes, it's helpful. Thank you.
Okay, case 3. Here's the good one. Lucy is a 76-year-old female admitted from a SNF with signs of sepsis, heart failure, and advanced dementia. She has a post form that says she signed 2 years ago that indicates her decision for DNR comfort only. When staff at the facility called to inform her daughter Jennifer that Lucy's condition was deteriorating, Jennifer demanded that her mother be transferred to the hospital. When you call Jennifer, she repeats her demand forcefully that Lucy receive aggressive treatment and be listed as full code. Has this ever happened to you or someone you love? No, it's never happened to Dr. Yoder. Careful. How would you navigate that?
So first, make sure that Jennifer was the one listed as the healthcare rep. I would assume that was the post form, so they usually designate someone on there. It's optional.
It is optional to designate someone on there. Let's say, for the sake of this case, She's not designated as the healthcare representative, but she's the one the nursing home always talks to in the hierarchy. She's the only one on that level, just for the sake of simplicity. But I see where you're going.
I would consult palliative care. I would also discuss with Jennifer that her mom expressed the wish to be in our comfort by filling this out. And that is, as far as we know, what she would want to be done. So that it takes the pressure off of the daughter making the decision, whether it's a decision the mom can make.
So really great response. So when you call her, what are you going? How's that conversation going to go? Give us some verbiage. Hi, Jennifer, it's Dr. Tim.
Yes. What do you understand is going on with your mom today?
Yeah.
And kind of see how, does she realize the gravity and severity of the illness? And I think mostly just letting her guide the conversation and then a little bit. Because I've seen a lot of times where we will come consult palliative care, but I'll talk to Dustin afterwards and they'll say, family just had to talk for a few minutes and then come full circle and realize, okay, this is not going to go well full code.
Sure.
Let's make her comfort.
Sure. Or the family didn't really understand the scope of their illness. You know, by the way, people have been, by and large, not able to visit their loved ones in SNFs for long time, weeks, months, longer. I mean, this is a long time to really not have that hands-on appreciation for how mom, dad, grandma is declining over that time. You know, sometimes that can take a quick turn, and sometimes that's kind of slow stair steps. That if you still have this picture from February of 2020, may not be accurate in January of 2021. That probably isn't. So yeah, I like how you give the person kind of space to figure out, to tell you what they know about what's going on. Yeah, that's a real good response. Others? Anything on the Zoom chat?
I don't see anything on the chat. No.
Nothing on chat? Okay. No problem.
I think sometimes with this conversation, it's just like, Nathan had said, like, in addition to that, I'll offer to do a FaceTime video if it's available, like that can see the one as well, so that I can understand, what they're actually like.
Yeah, that's another really great intervention. We kind of bring someone to the bedside as much as we can. It's really different when you can see, touch, smell, maybe feel what is going on there, and also appreciate the great care that you guys provide. You all provide. You know, that you're a doctor who really cares about what's the right thing to do here, not just checking the box. Go ahead.
Maybe speak to the emotional stress that this has on Jennifer. This must be really difficult for you if you know you're going through. How are you feeling? I think that can kind of show you that you're on the same team.
Absolutely. Yes. Great response. You're actually 2 slides ahead, so good for you.
I would just segue off of that, but I think also just aligning that the goal here is to get her better, and you also want to alleviate suffering. Trying to figure out, be able to articulate goals of care that align with Jennifer, with desire for her mom. And then at some point, there might be conflicting goals of care. You know, Jennifer wants her mom to be filled up and back at the nursing home at all costs. That might not be feasible.
Yeah. Yeah. So you're actually leaning into kind of where I thought this might go, but man, I'm blown away with the responses in the room. You all get like A+. This is wonderful. So sometimes these people are pretty forceful, right? They maybe have a different reason. You know, for all different reasons, they're pretty forceful about, no, I want you, Dr. Tim, to make her full code. I said to make her full code. So kind of what I'm getting at is when you call to make this call about we're visiting mom to the hospital, it's okay to inform them we're following the post form that she filled out to write these orders. You don't have to ask, what would you like the coach status to be? You already have medical orders in front of you that you can follow. Now, let me make sure I'm not skipping too far ahead of myself. Yeah, follow the post form. So in this scenario, admission to the hospital would really only be done under comfort care that was needed and could not be achieved without hospital admission. So a person's in a pain crisis, just massive distress. There could be some reasons for that, but people will help you with that. But the only reason really to admit them to a hospital in this particular scenario I've described would be as comfort care.
Lauren Janegi from the chat, she said,
Great.
She would explore Jennifer's emotions. So kind of like what
Yes.
I think what Kristen was saying a little bit too.
Yeah, excellent response, Lauren. Thank you. Yeah, so let's jump to this. Is this a mnemonic that people have seen before from Vital Talk, Adapt, and Remap? Allison have. Yeah, see some heads nodding, some heads not. So like we've got to some of this already with these three scenarios we've described. Probably when we call Jennifer, we're going to use step 3 here, anticipate some ambivalence. Your doctor who? How many times have you met my mom? What do you really know about her? All these things that we hear pretty often. Anticipate some ambivalence. I think Nate got to some of this, and Kristen got some of this already. Ask what they know. Seek to understand. What do you know about mom's condition? What did the nursing home even tell you? When they said they were sending her here. What have you known about the care for the past several months? All these kind of great questions. And then maybe provide some information, but we're going to also, down there at the bottom behind the box, track the emotion of the conversation. Jennifer speaking real fast and kind of worried and, needs a lot of reassurance, or is she kind of forceful and kind of wanting to drive the conversation? All that kind of can direct you in a few different ways. I think they send these slides out. Is that right? Okay, ask these slides to be sent out so you guys can have these as well. Sorry, you folks. I think you quit saying you guys. It's just a habit of mine. And then nurse, isn't this another mnemonic for communication and communicating empathy? Naming the emotion, it sounds like you're frustrated. Understanding, I think respect would be a good one in this situation. God, you really care a lot about your mom's care. I can tell that. I want to help. I'm here to help you. Or you're very concerned for your mom. Just validating the position that person comes from to help them feel heard and understood and take some of the wind out of the sails in the kind of oppositional dynamic. Any other good empathy statements that you all have?
I think, yeah, like reflecting that they not only care about their parent, but like I can tell that you're trying to do what's best for her, or I can tell.
Oh yeah, that's a good one.
Because I think that's helpful because, it's not just that you care, but also I can tell like you really want her to get the best care that she can and like the best situation for her. So I found that that's helpful sometimes.
Yeah, I love that statement, David. It's a really great statement. I can tell that you want the best for her as her doctor. I want that too. Mm-hmm. And then leave some space there. They may, cycle back into but they, accusations or you better, but leaving some space can help them kind of get that emotion out of you. Right, because you're confirming somebody's worst fears. Right? I've been doing chaplaincy for almost 9 years now, and the worst chaplaincy calls to go on are deaths and surgery. As soon as you walk around a corner, you are confirming everyone's worst fears that this thing that was supposed to go okay did not go through. Similar gradation to a situation like this, when you're confirming that family's worst fears that your mom's not going to make it as long as you thought through this Alzheimer's. So when there are problems, I couldn't get the animations to work right, so I guess this is up early. Asking for help is not a sign of professional weakness or professional inadequacy. Asking for help is not a sign of weakness or professional inadequacy. It's actually the right thing to do. And actually down there at the bottom, this asterisk, there will be problems. This won't always go smoothly. Consult ethics and palliative care. We talked through some of that already. There's a couple of policies that work in tandem with this one, the withholding and withdrawing policy. One is this long patient treatment conflict and dispute resolution, formerly known as medical futility policy. There's steps outlined in there for when there's a dispute between what the physicians feel should be done and what family wants done. It may be, you're talking, let's go back to this case for a minute. It may be, David, Kristen, you all do all the right things, great empathy, giving information, and we still end up with this yeah, I want her to be full code. I understand. Um, people do get in that situation. The dispute resolution policy gives us a process we can follow to find. Well, first, find if there might be another hospital to take this person, and then also go ahead and implement care that is actually indicated for the person. So in this case, I think it would be pretty clear to go ahead and start comfort care for this person. Go back here. Yeah, we're not going to resolve every single conflict with good communication. We'll resolve a lot of them. But if we're setting ourselves up to think we're going to resolve 100% of them, we're just going to be massively disappointed. Can't resolve every single one of these. Just a note here, remember, a policy cannot practice medicine. That's your job. I trust you to do that. I don't want to do that for you. You know, y'all are so much more better equipped than I am for that. This policy is intended to provide support and be explicit about the language, about what we can do, and just give that extra guidance at a hospital and at a system-wide level. This policy is now consistent across all IU Health hospitals. But exercise your best medical judgment. A piece of paper cannot possibly account for every clinical scenario. So Dr. Steiner raised a great one about, you know, a post form and a DNR from a SNF. I don't know. I need more information. Right? The policy isn't going to answer that on its own, but I'm sure we can figure it out. We can sit down and talk about what you guys want to do for this case. Support and help are available to you whenever you're faced with challenging decisions. Again, asking for help is not a sign of weakness. You can contact ethics to the hospital operator. We touched on this already. Myself and Reverend Bacchus are both available to get diagnosed. Feel free to reach out to us at any time about the case.